Well, here we are, another episode. How is it going today, Renee?
Hey, I'm doing great. How are you?
Doing good. Through the winter, it's always a little slow as a farmer. So I've been selling stuff online, cleaning up the
Oh,
farm and my basement.
wow. All right. Cleaning out things, huh?
Cleaning out, got rid of some excess equipment. I had a big iron auction, got rid of some things out on the farm. And then I started going through some boxes in the basement and got the old eBay account just roaring right now. So I'm excited.
Nice. Getting ahead of spring for a spring cleaning, huh?
Absolutely. So, it's always those things I put off. So I kind of keep stuff now and then. So this way it helps me to maybe move some stuff on out the door.
Yeah. Well, that's good. It's good because you got some things to do. You always have to have some of those winter projects, right? Because there's just not enough for you to do in the wintertime.
And this one's been a long, cold winter. So it's been nice to have something else to do. I have to be active. And so this has been kind of fun for me.
Yeah, that sounds like it. Well, last week, Jason, we talked about the big picture of what a behavioral health system should look like and kind of talked about where the policy is going at the federal level, kind of where the future kind of hope lies, and then looking at how it doesn't exactly look like that when you talk about it in practice. But as we start talking about this, we're going to look at some gaps and talk about some best practices of what we expect to see improvement over time and how we think about that. Because I know, Jason, you've talked about this before, but if the bar that you set and you set it at this level, but the bar itself was a terrible outcome. And you said that about a project a little while back in one of our previous podcasts that everybody was like cheering because you were ahead of the national average, but the national average was garbage. Well, that's not exactly what we're shooting for here. So we're going to talk about today kind of that lowest level of care, outpatient care, and how does that work on the continuum. And we're going to talk and dive into like how it's been different on the behavioral health substance use side versus mental health side, how those two things have been different, and then how they really should work together and kind of those best practices. So how are you doing, Jason? What are you thinking about outpatient care today?
Yeah, in some ways, outpatient is the most important because it's the access point. And
That's
so,
right.
if we have a really robust, strong outpatient care model, we keep people from needing higher levels of care, which are more expensive. And so, if we were more supportive of that introductory level of care, then think about how much money we could save the system. And unfortunately, we see a lot of different data points where outpatient isn't accessible or it's underutilized. And I think part of it is to have a conversation briefly about why aren't we utilizing this level of care, or is it really as hard to access as sometimes we hear that it is? And sometimes we hear something and then we think that's true just because somebody told us something. And that may not be true at all. Like, the wait times to see an outpatient therapist or to get a medication eval is 6 months. Well, then I ask, well, did you call? Well, no, my neighbor told me that. And I'm like, well, that may or may not be true. So the first thing we got to do is see if this is true or not. The other thing I think about is there's lots of ways to access outpatient care. And I think about EAPs, right? So employee
Mm-hmm.
assistance programs and how underutilized our employee
Mm-hmm.
assistance programs are. A lot of people at jobs who have an EAP program have like 3 free sessions, 3 to 5 per incident or per thing that they want to go talk to someone about. And a lot of times that includes family members. And that utilization rate is still only like 3 or 4% at most companies. And so, it's gotten a little better over the last 3 or 4 years. And so just kind of some random thoughts I have about outpatient is why are we not utilizing it? And why aren't we putting more focus on that introductory first step toward acknowledging that maybe we need some support?
Right. Thinking about EAPs, I work as a clinician on the backside and support a lot of different EAPs apparently as the therapist that'll show up when you get a call. And so there's a third party vendor that sort of connects the therapist to whatever the business is in their EAP. So the thing is, nobody knows the business I work for. And that's the point because I'm there to support whoever EAP it is. But if you've seen one EAP, you've seen one EAP. And I know you've always said that, but I've actually got to experience that recently because as working with some of the crisis things that happened back in January in our community, I got called to a couple different locations, and one would be, 6 free sessions and you just dial a number and you're basically connected to somebody. This other one had like all these hoops people had to jump in. You had to call for the EAP, you had to get a special code given to you. And then once you got the code, somehow they gave you like a list, but then basically you just had a list of people in your community, and then you had to make calls to the list and you might find somebody. Very different than any EAP I'd ever been on. When I worked at EAP myself back in the 90s now, man, it was my job to make sure people were connected in so many days, and I had to track them until they not only went to their appointment, but to make sure they felt satisfied on the back end. And so for those out there listening that have an EAP, and maybe you're part of the HR department or people that can make choices in that space, man, make sure you shop and know what you're getting with an EAP, because goodness, some people, it's really simple and they can just get help right away. And others, man, it's a lot of work for them to do it. And so that may be driving down those numbers of utilization if it's like this multi-step process, and then you add any kind of language barriers, and what a disaster. But as we're talking today, we're talking about outpatient. And today we want to talk about not just the outpatient appointment, but also some other pieces of outpatient that include like intensive outpatient, which is multiple times a week for a series. We'll talk about that some. And then assertive community treatment, which assertive community treatment we've implemented in our state was added when we talked about complex needs or persons that had more additional needs. And the idea was they still were in their home, but it wrapped around a service around them. And I guess the other piece that we'd have to talk about in this space too would be integrated health homes, because that's still on the outpatient side, but more of that wraparound case management, often connected to managed care. And so thinking about all of those levels, we're going to be talking about those some more and kind of what those are. We'll talk about kind of defining those out. So Jason, as you start thinking about that and you want to define them, what is an intensive outpatient treatment? What is that? Tell people what that means.
Yeah, I also think about psych rehab, right? There's lots of specialty care. And
Yep,
so,
I agree.
when I think about specialty care, I think of those programs that are more intensive, but you're still at home, right? You're going to treatment, you're going to groups, you're going to something. It just depends on the intensity, right? So really it comes down to hours per week, right? So if you're in an intensive program, you're going to more than just a couple of hours a week, right? It could be 3 to 9 hours a week of going to a combination of groups and individual services, right? And so sometimes that level and intensity can be very beneficial because it keeps you from needing to be out of how do I say out of home sounds weird, but placed somewhere like a residential treatment facility, or a short-term subacute type place, right? So instead of going and having to live somewhere for whatever duration of time, trying to get those same more intensive services from home, right? And there's lots of different ways, and they look like a lot of different things, and I think it's different depending on where you're located. I think that's part of the barriers here is when we think about intensive outpatient, usually you have to drive somewhere, right? And so most providers would have to have a group big enough to be able to do that. And so if you live in a really rural area of our state, then it's going to probably be more challenging for you to get to some of those services. Another policy issue that we have is that sometimes you can't have more than one appointment on the same day. So if you go to a group, you can't also have a med check, or if you go to a group, you can't have a med check and an individual appointment. And so there's some weird policy things we've done that have tied our hands around some of these services as well. And that makes it even harder for people to actively engage in.
Right. So thinking about assertive community treatment, that's another evidence-based program that we like to chat about, because on paper, it sounds like it should be a great wraparound service for people in their homes, which the team itself is pretty big. It's supposed to have different types of specialists on that team and whatever. And that becomes a challenge in rural communities to have enough providers that could be on a team. And I know that we've been working in our state and across the country on kind of a rural act kind of model as to what that could look like, because assertive community treatment, the idea is you have a team of experts all around, kind of wrapped around a person. You have a main caseworker, main person that stays in contact with the person coming to their home or talking to them frequently to make sure that they have the services. But then that main contact can reach out to a nurse, a psychiatrist, specialists, sometimes in occupational therapy or physical therapy or whatever those types of things are, to get the person connected in a way that they can stay in their community longer and not have to go to a facility of some kind. But looking at how do you keep people there. But it gets really complicated if this is one of those places, Jason, I know we talk about people want perfection over progress. And so they won't make assertive community treatment program because they're afraid they don't have enough of the workforce, they don't have enough of the specialists, and so they just don't try. because we're shooting for, well, we can't do that best practice, evidence-based practice, so we're just not going to do it at all. And so we want to talk about today about evidence-based practices, but talk about that space. Like when we're talking evidence-based practices, what's the goal? And then in rural communities like where we work, why should that not stop people from moving forward?
Yeah, ACT team is a great example, right? And unfortunately, what we've done a lot of times is we've linked fidelity to an evidence-based practice to funding. And you have to some extent. But unfortunately, sometimes we cut our nose off in spite of our face when we do that, right? So an ACT team, is typically a team surrounding a prescriber. And so that could be an advanced registered nurse practitioner. It could be a psychiatrist, right? And so you have the prescriber, you have a nurse, you have a social worker or a therapist. You have a peer, someone with lived experience. Sometimes you have an employment specialist, someone who's there to help employment coach and do all those things. And so really you're wrapping yourself around the person in their own home. So that person doesn't need to come to your office. The whole team goes to them. Right. And it's phone check-ins. But I've seen the most successful ACT teams where it's the prescriber when someone gets a call and says, Joe didn't show up for work today. We're concerned about him. He's been off. Well, generally that would indicate a medication issue. And so when that prescriber can go to someone's home and do a home visit, right? Kind of like the old time doctor who used to go around, and see you in your home, we've kind of gotten away from that. But that model in this case is much more rapid in responding to that medication issue, helping the person to figure out, a different path forward, working with, also pharmacists and others, and keeping that person on track. It decreases the number of days that they're not working. It decreases the number of days they need to go in for inpatient care. All of those things that happen when we're working with some of the most, chronic, difficult to treat patients. Those little things make a huge difference and drive down the cost overall a whole lot. And so that's the challenge we find ourselves in. And when you're a rural area, you've got a lot of miles you're going to log if you're going and doing home visits. And so sometimes people are like, we can't do that. We can't afford that. And so as a provider, I can understand that perspective because it is very expensive. However, we don't do a good job of quantifying how much are we saving the system overall. Because if across the 10 county area, we can keep 50 people from going to the hospital that year, we've paid for our ACT team. But that's the challenge that we face. And so we get into these kind of wrestling matches in rural areas, especially as to should we have an ACT team or should we not? And how are we going to fund it?
Right. And we talk about this. The evidence-based practices are often thought about at the more urban community areas. And so when they designed an evidence-based practice around an ACT team and all the members that were supposed to be part of it and how many people you were supposed to serve in that team, all of that, they did not at all consider rural communities. And so, the sheer volume of people to be an ACT team to be viable, according to the evidence-based practice, is oftentimes larger than the number of people that need served in a general county or a general region area. And so, there's a lot of people, there needs to be some sort of kind of an adjustment and a conversation about, okay, if this is best practice and at that bigger level, what would the best practice be in our rural communities? And it's going to be serving fewer people. So the cost is going to be more, to your point about driving further and it taking just longer time per appointment because you're just physically spread out further. And so how do we, try to make the funding option available so that ACT teams can be successful in those more rural areas where it's not the program itself is really good and it has the evidence to back it up, but you can't do it exactly the same way. And so sometimes our rural communities get stuck and are like, oh, we'll never be big enough. We don't have enough supports, so we can never do blank. And sometimes that's really bad. So when we're talking here about evidence-based practices, sometimes just the name that says that puts people off, like, well, we're not even going to try that service because we could never hit that level. And I think that's a real shame because the general idea is really good, even if it doesn't meet that huge standard.
And it's not just ACT teams, right? We
No.
know that lots of types of treatment for kids, family therapy, is best done in home. And so, having family therapists go to a home, meeting with mom and dad and the kid all at the same time, especially when substances are involved, has far better outcomes. But there are very few programs who are following some of those models that actually have the best outcomes because you have to have a therapist who's willing to drive 2 hours, go to someone's home, and usually there's a social worker who's making sure everyone's going to be at the appointment, managing some of those things, right? It's a much more intensive services. And as we think about outpatient, all outpatient isn't the same, right? And I think that's really the point of this conversation is there's lots of different levels of outpatient. And
Right.
so, how are we better differentiating? It's different when someone walks into an appointment once a month, once a month or once every 2 weeks and meets with their therapist, and then every 3 months meets with their psychiatrist. It's much more medical that way. But there's some different levels of intensity that we can introduce to the outpatient spectrum that are going to keep people in that outpatient level of care continuum so they don't need then those higher levels, more intensive levels of care that we're going to talk about in upcoming podcasts. And so sometimes we forget that there's all these different levels of outpatient, levels of intensity just within the outpatient spectrum. And how can we better support those models? And unfortunately, our managed care companies and sometimes our state just say it's outpatient. If you're going to provide outpatient, it doesn't matter if it's just going to be 50 minutes. Well, that doesn't work when we look at actually these evidence-based practices that actually produce outcomes that we have some solid data around. And I think that's the frustration sometimes we feel in the system when I talk to providers or I talk to regions and districts who oversee some of these things, is thinking about how can we find balance between those two things.
Right. And I try to always remind people, if you're a person that uses outpatient services, to Jason's point, if you've seen one, you've seen one. And what's really difficult is, outpatient can be funded multiple ways. It could be federally funded, state funded, regionally funded, or it could be private practice. And if you've met one therapist, you've met one therapist. So sometimes people will throw that out with the bathwater, and I'm not doing outpatient therapy because I tried it once and it didn't work, or I tried it once, I didn't like them. Well, that may be 100% that you didn't get along with the provider themselves or something specific. And so you don't just quit the whole concept. So if the goal is to have assistance in that space of outpatient, then you've got to keep looking because maybe it's something different. And you think about people that have addictions. I've had some folks in my family with addiction and different types of treatment. Some helped, some didn't. And so they had to keep trying. The goal was to get help with their addiction. And to do that, intensive outpatient ended up being the trick in the one case. And that was after failed attempts at other things. And so, you're thinking about what else is out there. I know another level of care, Jason, that now comes more with the managed care companies, but our hospital systems have is integrated health homes. And integrated health homes is something that was written into our code as kind of a core service. I'm guessing it was written in probably when I wrote the code originally back in 2011, but it was more about at that point whether or not they had the funding to do it or not. But then it became more of a standard program, but it's a little different than ACT teams, but yet with the same concept of helping somebody stay home, but having a health home wrapped around them. You want to talk more about that?
Yeah, well, I mean, I think the intention was to provide care coordination, right? Help to get through all of the barriers you have. So whether we call it a service navigator, a care coordinator, again, all of those things are really great on paper. But unfortunately, we created a system where we have to have a service navigator or a care coordinator to even figure out how we're supposed to go to our first appointment. And so I think it's kind of representational of the failure of our system today. Is it that there's so much bureaucracy to even get a care coordinator? It takes months to even be able to get one with so much paperwork and bureaucracy that you now need a care coordinator to get a care coordinator. And so I think that alone pretty much symbolizes why our mental health system fails to serve the people it needs to serve, and why addiction treatment, those who need treatment, only about 10 or 15% will actually get the treatment they need nationally, right? So I think those statistics are very telling. It's mental health, it's a little better, but you're still going to see 60% of the people who need treatment not get care in the next year. And it's because we create barriers and we don't have appropriate systems and structures in place to support people to even get outpatient care.
Right. And to your point, the data shows for outpatient use, there's a study that was done back in July of 2021 that the wait time at that point was the mean, meaning in the middle, was about 5 months, 92 to 212 days for getting into an outpatient appointment. And that was in 2021. That's more of a national average and a national look. But we know here in our state that that is a thing. There's a delay for people to try to get as a new patient. And so a lot of times it's sort of like nowadays with, and it's not just mental health, but any kind of doctor, you kind of need to get on the list and, get yourself in so that you're not a new patient, so that you can be on the list when you actually need it. You kind of have to get on a list and get into a system. And before you know, you actually have to have it. And in mental health, a lot of folks don't think about that before there's a crisis. And so by the time they are saying, I really need the help, and are willing to break that stigma to talk about it, then the wait time starts. And so because they're not a new patient and they have to start from scratch to get in. And those wait times really delay getting people when they've decided they want help. They can't have access at that time. And by the time that they might get an appointment, they really might have changed their mind by then and been like, oh, forget it. It's not worth all of that.
Yeah, and I think that's part of the barrier, because sometimes we hear that, and working with providers and doing some local efforts, where I get to sit with providers across the 12 county area and ask once a month, do you have a wait time? Do you have a wait time? And I'll have one provider tell me, yeah, we have no therapist right now, so it's 6 months. And I've got another provider that says, yeah, we just hired somebody and we could take someone in tomorrow. The system just doesn't communicate. And so as someone who's seeking services, unless I know to call all 22 providers in a certain area to find the one who has an opening, 9 times out of 10, I could find someone an opening. But unfortunately, I'm inside the system working with people all of the time. And so I know who to call, where to call. The system shouldn't be so secretive, right? It shouldn't be about who you know to get an appointment. Unfortunately, I think so oftentimes that's where we find ourselves today. And so I kind of hesitantly, sometimes I disagree with some of those numbers I hear because it's all doom and gloom. Like, oh, we can't get a psychiatrist. There's none that are here. But I also know how dysfunctional the system is. And I know that we duplicate services all the time. I know that we create our own barriers to not being able, I've been on the provider side of this. I've managed clinics and I know how inefficient some of those clinics can be. I also know how efficient clinics can be when they're ran well, and staff feel good about their jobs, and so all of those things have to be aligned, and it's just not today.
No, I think of a state that we worked in, Jason. I'm going to jump ahead because the story is so relevant to this conversation. But we were in a state where the time that I worked with them and we were talking about beds and like getting people through the system, the people had a forever caseload. Basically, nobody fell off the caseload unless they died, like literally died. And so the caseloads were, quote, full. Well, now a whole lot of those folks were inactive, and a whole lot of those folks hadn't been seen for years. But because they were, active patients, they couldn't take new people. And literally hundreds and thousands of people on these rolls who had not seen services in who knows how long, but because they never got them off the books until they died, and then who knows how long it was until they actually saw the data on that to actually remove people. And so to your point, talk about inefficiency. People were counting their 500 people and they were so full, but maybe 10% of that were active cases that actually needed help. And to be fair, having also worked in these clinics, a new case takes more work up front. Yeah, you have to put more effort in before someone's stable. Yeah, it's easier to take people that you've had for 5 years who you don't really need you anymore because they don't ever call you because they've moved on with life. It's easier to have a whole caseload full of those than to take somebody actively in crisis. But that's not what the system is designed for. And so literally had to tell the state, and I think the state didn't really get it, that's what, I don't think they had put two and two together that that's conceivably what they had built. But they had built a forever caseload, and until you died, man, forever shall you be on a caseload. And when you say it out loud, it sounds ridiculous. When I said it out loud to the state leadership, they gasped and were like, oh my gosh, that's not what's supposed to be happening. But 100% that's what was happening. And so sometimes, to your point, Jason, it's just designed incorrectly. So the design makes it so then the caseload's full so that you don't have openings. and it's designed that way. So sometimes this opening thing is an issue. And when we get talking about beds later, and we talked about this some when we talked about what's a bed, general consensus in our state and many others is there's open beds at any given time. The issue is they're not the right type at the right kind in the right location for the right people. And so it's not that it isn't openings. It is, to your point, the communication is lacking, the cooperation is lacking to be able to work together to figure out exactly where to get somebody in the right space. So all the stuff about navigating, all the stuff about care coordination, for what? It's not actually happening. Those are services we pay for. I don't get it. To your point, they're not navigating anything or coordinating anything. And so that's a little bit weird. And they probably have these caseloads up forever. So hot mess. So talk about, Jason, we also have shortages of providers. And this is also another excuse we hear a lot, but there's truth to this. There really are shortages. But what in that space about provider shortages do you want to share about what that looks like? And I know we're going to have some stuff in the show notes where people can see what this looks like, what the current data is. But how does that impact outpatient and wait lists and all of this conversation?
Yeah, absolutely. And so certainly we don't want to take away from the fact that we don't have enough psychiatrists, therapists, pharmacists play right into the fold of this coming into the system, right? Especially in rural areas. Folks just aren't going to school at the rates we need them to. So we're not having enough folks coming out of our education systems who are going to fill the needs of, upcoming retirements or even the gap that we have today. So is there realistically workforce shortages? Absolutely. Now, kind of going back to Renee's point, we know with bed tracking, we know with knowing about beds, we know that there's capacity at different places, right? And we do a really poor job of knowing where we have capacity and where we don't. And so oftentimes I get into these systems like we can't control it. Yes, can we recruit more people? We absolutely can, but we also need to look internally at our systems and structures. And are we inherently set up to be constantly shorting ourselves because of our own self-imposed rules and regulations that are completely disjointed from reality? And I see a whole lot of that when I go around and when I go to hospital systems or other places. I'm like, well, why do you all do that way? Because you don't have to. And you're actually creating 3 more appointments as opposed to being able to do everything at once. Now, will it take 90 minutes? Maybe. But if you could do it in 90 minutes instead of taking up 3 appointments, you're going to free up a whole lot more time. And so sometimes we see folks doing things the way they've always done it, and it doesn't make any sense anymore. And so, really thinking about, is this really a workforce shortage, or is this we're not using the resources we have in front of us? And I'm much more, me, Renee, I love to talk about how are we going to use the resources we have to their maximum, not worry about what we don't have. I can't control what we don't have. I'm a farmer. I'm stuck with what the weather is going to be today, and I'm going to make the most of it. And so I take that same approach when I'm working with folks.
Right. I know this isn't just a behavioral health thing. I'll use a personal example here, but I remember when I came out of the hospital in 2013, I'd been there for a lung infection a long time, and I left because multiple things had happened during that extended stay. I think I had 6 different doctor follow-up appointments after that hospitalization. I literally left with a list of people. And I remember very specifically calling back and saying, who of these people do I actually have to go see? And whittled down the list to like just a couple, because there were doctors who had come and gone while I was in there that I don't even remember meeting, and things that had happened. And I had a follow-up for all of them. So to your point, I had this issue, and it was not a good issue. I was there, I was really sick. But afterwards, there was 1 or 2 people that really needed to be following up with me to help me get through it and navigate what the next season was, not 6. And so that whole inefficiency just in healthcare in general, where, taking up 4 other people's time slots for what, when they weren't even anything that really impacted where I went to go. So luckily I had the ability, and I've advocated for myself and enough people long enough that I could make that call back and be like, look, I ain't doing all of these. So who exactly do I need to do? And then we're canceling the rest of this garbage. And so then it just got it down to the bare minimum, but other people don't know that. And so when they leave a place and they've got, this appointment over here and that appointment over there and that appointment over there, say that there's transportation issues or there's childcare issues or trying to get off work issues. If you work 9 to 5, like I have right now, it's hard to get to doctor's appointments, especially if you have only daytime hours. And so you've got all these challenges we're putting up and barriers into the system we don't even think about. We don't think about that. There's some real obvious barriers, but then there's all these extra things that we're kind of adding. And I know when we talk about challenges in the systems where we've worked, you've seen some others of these. Do you have any other stories you wanted to share?
Well, I would just throw out there that there's one other solution, and it's not just in more acute levels of care. It also is an outpatient, no eject, no reject, right? Sometimes we need to just take patients. And so sometimes systems need to be held accountable to serve the people that they're supposed to be serving. And I think sometimes that takes up a lot of time and space, where patients simply are left kind of hanging out there waiting for something. And so I've kind of, as a provider, I didn't like those words at all. It was scary, and I've learned that, you know what, this is actually helps the entire system to become stronger. And when you have a lot of people working together, right, it goes back to care coordination
Yeah.
and true social work, right? If everyone's working together toward common goals, then we actually maximize efficiency as well, right? So everything goes back to efficiency, but someone has to hold the system accountable. And so those levels of accountability are important in a system.
Yeah. And just imagine if people had really a home of where they were always going to be brought back to for services, regardless of whatever happened and how terrible it got, there'd be a lot less of it. Right now, a whole lot of the noise in the system is just the bouncing around from this person got bounced from this agency to that agency to that agency. And so it feels like there's a lot more people. And I know that to be true when we talked about IRSH homes earlier, those intensive residential service homes. The number of what they thought we needed once they figured it out and dove in was 120 for a state of the size of Iowa. And Iowa's not a massive state, but for 3 million people, it's really 120 that are making all the noise in the system. And that's really where your high cost comes from. And that's where your bouncing comes from. But it feels like so much bigger because everybody's impacted because they keep bouncing. And so if you could get them all stabilized in a home structure, no eject, no reject, where they always go back to that provider, all that bouncing stuff and all that wasted time of all the bouncing would subside, and you'd figure out it's not as big of a deal. So there are some structural pieces to this conversation that there's hope to improve.
And if you think about it, we do that with medical care. I
Yeah.
have to go through my primary care physician, right? He's the gatekeeper for
Yeah.
pretty much all of my health care. And so in reality, that's the way our systems are structured in other areas. And so I don't know why we haven't embraced the same model for our emotional well-being, because in my mind, it would be the same thing.
Well, at least within the medical system. So if you're a Mercy medical person or a Unity Point medical person, because your healthcare goes here or your healthcare goes there, you're generally limited to where you're going in that space, to your point. And mental health is not like that. People can just show up anywhere. And because they show up anywhere and everywhere, the duplication of first appointments and first assessments is high because they go get a new assessment here, 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 and here, and here. And that's crazy. And so I know that that's the goal of the navigators and the goal of those care coordinators, but that really needs to be it. There needs to be somebody that's sort of like, this is your primary care location and you need to stop there. And I know that was what the goal of integrated health homes were, and the same kind of concept, but I just don't think we've got it rolled out the way we thought we could on paper, because it just seems so much to your point of just everybody's bouncing. And the more we bounce, the worse it gets. And so it just creates turmoil in the system. Well, as we transition off today, before I go into the self-care thing, I'm going to just say one more thing, and this is going to tie into next week's episode. Next week, we're going to dive in to start talking about crisis services. And one thought I want to leave everybody with, because this is my soapbox for the day. I love this topic, but when you're in an emergency department and you're in there for a crisis, don't give somebody a card for an outpatient appointment 7 weeks out, 8 weeks out, 10 weeks out. Outpatient is not your next best step. If somebody's in crisis, they need crisis services. Outpatient's not that. And so we're going to talk more next time about crisis services, because that's the right place to get somebody in crisis, is somebody to get services when they need them. And so outpatient's not that space. So I just want to clarify before we jump off the page today, outpatient is not your follow-up care out of the emergency department. That's just not the right spot. There's a great place for outpatient care. That's not it. So let's talk today about the recovering politician self-care policy. Today's tip: ask for help. I'm telling this to myself as well as others, but sometimes when you're working on things, you need to think about it before it becomes an emergency. And think about your car, things going to break down. Jason's doing this with all of his equipment right now, thinking about what needs to be fixed, what needs to be adjusted, what needs to be ready. So when he can go to plant, he's ready to go, right? We have to get help sometimes in advance of the crisis so that we can think about what's going on. So we talked a little bit back. I've been working on some more things in that recovery space, and I've learned that I don't react to stress quite like I should. My body doesn't do all the things it should to kind of bounce back as well as it should. And I don't know what to do about that. So I'm going to have to ask for help. And there's nothing wrong with asking for help. And in self-care, sometimes we just don't know what to do. Maybe you're a person and you would like things to get better. You'd like your mood to improve. You'd like to be less stressed. You'd like to feel better about your life and feel like you have a better purpose. Well, you have to ask for help. And there's no shame in doing so. So today's tip, when you get stuck, whether it's for your physical health, your mental health, whatever it is, you just got to reach out. Somebody's going to know what else needs to happen. And when you're thinking about, things that are broken down, we're all working on that right now. Even Jason's got all his equipment getting ready to go in the field. And you can't do that unless you've called your mechanic. I guess, well, I don't know. Jason, you fix your own stuff, right? Or do you
As you were talking, I'm like, boy, this isn't more relevant to me right now. Yeah, all of my tractors and combine are going in. The tractors have been in for the last month and a half, getting checked out at John Deere. Because sometimes I can't do it all myself. And so they do a full, complete, comprehensive check over, and then they give me a really long list of stuff that needs to be fixed. And it's really painful. That's part of why I'm cleaning up my basement, trying to make some money on eBay, Renee. I have to be honest. Sometimes asking for help can be expensive, but you got to take care of those things, right? As we get older, just like as my equipment gets older, I've got to invest in that equipment if I wanted to be reliable and be there for me, when we're planting and spraying and then combining this fall. So, it's not more applicable because sometimes we all have to ask for help and we have to go to those specialists who can provide the help that we need. In my case, it's a John Deere mechanic. But I think that's really wise advice.
Yeah. Well, the day we started talking about outpatient care and some of those best practices and some of the levels of care that are in outpatient, it's more than just that once a week therapy appointment or the every other week appointment. It's more than that. There's a lot more things that are available to people in this outpatient space there's more robust, there's more options to help people stay home and to get the services that they need wrapped around them in the community. And so thinking about what that could look like, we also talked about some challenges we face with wait times, with provider shortages and all of that. But we do know that there's a lot of things that we can do to help make sure that people really can access the programs. And what people need to hear is that you need to keep calling, you need to keep asking, because there's more doors open than you know. And just don't take somebody's word at it. If you get stuck on the list, you got to keep looking. So next week, we're going to dive into crisis services. We'll see you guys then. Have a great day.